All right, President Chin, back to you.
Thank you very much. Is there a motion to move to resume open session at 8:30 a.m.?
Oh, I'm sorry, Steph Monroe, you said 8:30. It's 10:30.
Excuse me, we're at 10:30 a.m. My God, it's not p.m. So, board member Beeman. Thank you.
Again, Vice President Joyce.
Thank you. Board President Chin says yes. Board Vice President Joyce.
Yes.
Board Member Beeman.
Yes.
Board Member Hall.
Yes.
Board Member Hemmons. Yes. Board Member Kirkbride.
Yes.
Board Member Kroger.
Yes.
Board Member Patel.
Yes.
Board Member Pinedo.
Yes.
Motion passes unanimously. Okay, it has come to my attention that we need to amend the agenda to add the vaccine protocol process. Is there a motion to amend the agenda to add to the general administration section of the agenda, vaccine protocol process? I move Board Member Beeman.
Second, Vice President Joyce.
Hey, Board Member Chin, yes. Board President Joyce.
Yes.
Board Member Beeman.
Yes.
Board Member Hall.
Yes.
Board Member Hemmons.
Yes.
Board Member Kirkbride.
Yes.
Board Member Kroger.
Yes.
Board Member Patel.
Yes.
Board Member Pinedo.
Yes.
The motion passes unanimously. And do we have any board discussion? I think that we wanted to kind of rehash the conversation about why we would like to move the vaccine protocol to PFAC. We had requested that the vaccine protocols be addressed and looked to revise them so that they are not so cumbersome. And we had a grand discussion about that. So I would like to start with Board Member Hall on why we would like to move this to PFAC.
Pass.
Patel?
Board Member Patel, it seems to me like there is no other choice. Like we have to go through the feedback, right? But then my concern is, I also heard that there is a 3 pharmacist who was providing volunteer service for the immunization. Either they quit or they cannot do that service. So concern is like, how long it will take, and then come back to board, and then we have to vote. That is the one concern I have, the timeline, time consuming, and these things just keep changing so fast. If anyway, if the board as adopt one like standard protocol based on the state like Virginia, like standard of care protocol for immunization, I think that is the fastest way, and recommend follow the ACIP and CDC. So that's my concern.
Kirkbride. Board Member Kirkbride, please.
Board Member Kirkbride, our hands are a bit tied with current statute, and statutory changes are not fast. So I think our best course of action right now is to utilize our committee, who, currently this work is in their hands. I do think there's a lot of opportunity for streamlining, and I would put confidence in our new pharmacy consultant and the chair of that committee to take that action with board direction.
Yeah, Board Member Hemmons? No comment. Board Member Kroger?
Board Member Carter, I agree that the PFAC should be handling the protocols, and that my preference would be that the board direction is to streamline the protocols into 2 protocols referencing ACIP with the updates, incorporated by rule, and that be the only changes that we potentially need to deliberate, and just so that it's very clear that what streamlining means to the PFAC, not have 20 protocols, one for each vaccine available, but really simplifying it for the licensees, knowing, where the source of truth is, and that, we still continually as a board review and make sure that we're, not approving something for perpetuity, but but utilizing the experts at ACIP.
Board Member Beaman.
Member Beaman, I'm comfortable, accepting the feedback to streamline it and, again, like, just like what Member Kroger was saying, give the direction of, there's a lot to minimize here. There's a lot to cut back and cut down and see what this feedback will come up with.
Member Pineda.
Member Pinelo, nothing to add.
Member Joyce.
Former Joyce, nothing to add.
Board Member Chin, I wholeheartedly agree with Board Member Kirker, but I have a question regarding, you had specific age ranges, I think, starting at age 7. And I think that there are babies who are now allowed to be immunized.
Member Kroger, it is, the general, whatever our statutory limits are for pharmacists, which I think is pretty clear what age minimum,
I just wanted to make sure that
yeah.
that was stated.
yeah, basically a childhood and an adult version of. the
Exactly,
protocol,
right,
yeah,
and
whatever
that's-
those ages are.
Thank you, because I am just thrilled that pharmacists are allowed to do babies. I think the more people who have access to being able to immunize, because we are vastly under immunized in our childhood population in the state. And we need everybody on the same path to get as many bodies immunized as possible. So thank you. And I agree with the direction to PFAC, and thank you. And Board Member Hall.
Board Member Hall, nothing to add.
So
Board Member Kirkbride, I do have one more comment. I just want to be careful when we get to our motion. I don't think we should include our motion to lump them all together, because the fact that we have a protocol for each vaccine was based on previous legal advice. So I think just keeping it open to getting new advice and streamlining as much as possible. I know streamlining is a hard word, but let's not be too
it is in perspective.
let's not be too directive so that we're halts if that's not possible.
So, Board Member Kirkbride, the motion is in prescriptive, but having the PFAC hear what board members' intent are, it was what the reason for the conversation in that regard. But the motion doesn't have that language in it. Help? Okay. Is there a motion to have the Public Health and Pharmacy Formulary Advisory Committee review the existing vaccine protocols to draft streamlined vaccine protocols?
So moved, Board Member Kroger.
You.
Second, Board Member Pinelo.
You. So, Board Member Chin, yes. Board Member Hall. Yes. Board Member Patel. Yes. Board Member Kirkbride.
Yes.
Board Member Hemmons.
Yes.
Board Member Kroger.
Yes.
Board Member Beaman.
Yes.
Board Member Pinedo.
Yes.
Board Member Joyce.
Yes.
It's a unanimous motion. Thank you so very much, everybody. Now we will go back to our regularly scheduled agenda. We're in the discussion regarding rules and consider adoption of temporary rules. This is going to.
All right, give me just a moment.
Thank you.
Share my
And
screen.
thank you, everybody, for letting, helping us to do this on the fly and getting something added to our agenda today.
All right, Staff Member Melvin, for those of you on the phone, this is mailing A. This is regarding Division 35, operation of non-prescription and medical device equipment and gas, or MDEG outlets related to registration requirements. I'm going to go over the gray box quickly. This proposed temporary rule would provide exemption to registration requirement. It proposes to amend the rule by adding an exemption to registration requirements for businesses or other establishments only distributing over-the-counter short-acting opioid antagonist drugs at no cost. The justification for filing a temporary rule is basically in 2023, House Bill 2395 was passed in response to the opioid overdose epidemic in Oregon. In order to support the efforts of House Bill 2395, and to get this life-saving, short-acting opioid antagonist drugs into the hands of people that can utilize those drugs to save a life, it is imperative that the barrier of registration as a non-prescription drug outlet be eliminated. The documents to be relied upon are simply the House bill, which is hyperlinked, and the rule summary indicates what we're changing in the rule and why, very similar to what I read up above. Again, it's just adding a carve out for businesses or other establishments who only distribute over-the-counter short-acting opioid antagonist drugs at no cost are not required to register with the board as a non-prescription drug outlet. And so in our rule 855-035-0005 applications, you will see proposed language, paren 14, a business or other establishment that is only distributing over-the-counter short-acting opioid antagonist drugs at no cost is not required to register with the board as a non-prescription drug outlet. Back to you, President Chin, for board discussion.
Ew. Anybody recall who I started with last on discussion? The arrow was a Kroger, so let's start with Member Beekman.
Remember Beeman, I think this allows for access, so.
Thank you. Board Member Pinedo,
I agree with that here as well.
Member Joyce,
Board Member Joyce, yeah, this is in the interest of public safety, you know, like clean needles and condoms, and this is, public health and, getting more, naloxone out there is, in the best interest of everyone.
Member Chin agrees. Board Member Hall,
Yeah, I agree. It's the good step forward.
Board Member Patel,
But Patel agrees.
Board Member Kirkbride,
I have no concerns with the language as presented.
Board Member Hemmons,
Agree.
Board Member Kroger.
Thank you.
So, hey, we're not doing vote on this right now.
I'm so sorry. The motion is not there. We need a motion for that.
Okay.
Thank you. And it's a temporary rule to be effective upon filing or immediately.
Is there a motion to adopt the temporary rules for non-prescription medical device equipment and gas outlet registration requirements in OAR 855-035-0005? Subject to, it'll be, effective on filing. Thank you.
Board Member Beeman.
Board Member Hall. Board, President Chin, yes. Board Vice President Joyce.
Yes.
Board Member Beeman.
Yes.
Board Member Hall.
Yes.
Board Member Hemmons. Yes. Board Member Kirkbride.
Yes.
Board Member Kroger.
Yes.
Board Member Patel.
Yes.
Board Member Pinedo.
Yes.
Motion passes unanimously. Thank you. All right. And we will now receive updates related to rule development with staff member Runyon.
One quick question, is there another place where we will vote to put that in?
Yes.
Not that we needed to do that but there was a temporary and a.
Permanent, but you
So
said-
we
Second row, there's permanent below after we talk about protocols. There's a second motion for to send rules to a November rulemaking hearing.
Okay, so that's
Coming.
it's coming.
Yeah.
Gotcha. So. Staff member Runyon. Rules and development, sir.
Staff member Runyon, as far as our proposed timeline for 2025 and the April rulemaking hearing, we tentatively planned, or May rulemaking hearing, we tentatively plan to send the drug storage rules, which are number one on the ranking list, as well as the RDSP to that meeting. So you'll see, first, second, third looks, et cetera. Before then, I plan to bring some of those to the December meeting. But yeah, the May 2025 rulemaking hearing is final on that. And then compounding, sometime perhaps later in the year would likely be November 2025. For the final iteration of those rules, it will probably take 4 or 5 looks and before we get some final approved consensus or iteration on those. And then we plan to start weekly rulemaking hearings or meetings once Bree gets back, so very soon, probably November. And then schedule some work groups early in 2025 to help us meet those timelines as well. So again, just to kind of revisit that, drug storage, RDSP, April or May 2025, and then compounding later in the year, and then weekly rulemaking hearings and
Not
work,
hearings,
work,
just internal meetings.
yeah, internal meetings, and then work groups to start early 2025.
Thank you for the update. Hey. Yes, board member,
Board Member Patel, so, Watkins, Salisbury, Runyon, you mentioned that there is going to be a work group,
No,
but a work group for which rulemaking? Like all of them, like compounding, drug storage, or DSP?
So we don't have anything planned yet.
Yeah.
I was just going off Jennifer's notes from where she left it, and in terms of her vision for what would need to occur in 2025 to meet the board's request. So there's nothing scheduled yet.
Staff Member Melvin, weigh in. There is not a public work group. The board has not asked us to convene a work group for any of these rules that we are bringing forth. So he was referring to our internal process. We have a weekly meeting with
Okay.
people from each department where we take everything that you've directed us to do based on the comments for the compounding rules. Like, let's do that as an example. Now we're gonna go through, bring all those comments back in and start bringing these forth to you, starting hopefully in February for compounding,
Thank you.
to get us through to potential consideration for adoption at November 2025.
Thank you for clarification.
heard your heart beating really fast. Yes. Okay, thank you. We will now review and discuss proposed rules with staff member Melvin.
Okay. Give me just a moment. All right, we will start with, this is going to be mailing B, and this is for the board's consideration. This is regarding the temporary rule. Oh, let me share my screen. That the board adopted during the August board meeting. We are now bringing forth the permanent version. And we are going to have to go through the protocols because we did have some minor corrections that we want to share with the board. So first, we'll just start with this. Again, this is the temporary rule that's already effective. So what the board is considering today is, again, sending it to a November rulemaking hearing for permanent adoption in December. And this is OAR 855-115-0345. And what looks different on this versus the temporary rule that's currently on our books is the version number. So you're going to see, this is what you will adopt or consider adopting in December. So it'd be version 12, 2024. And that's going to be for coronavirus 2019, influenza inactivated, influenza live, and our friend RSV. So this is the rule. Now I'm going to turn it over to staff member Runyon, and we're going to go through, we'll start with coronavirus and talk about some minor changes. Give me just a moment.
Staff member Runyon. So primarily the changes that we made were outlined in the August board meeting, and they were confined strictly to link updates. And there was also one instance where we addressed a change in storage and handling for one of the vaccines, and we were given legal counsel that wasn't considered a substantive change. So we were allowed to make that edit for your review without consulting the PFAC. So the first change to the COVID protocol is actually on page 10. And as Rachel scrolls down, it's just the removal of the recommendation for an additional dose for patients 65 and up, regardless of immunological status. So in February 28th of 2024, I believe, and the ACIP came out and said anyone 65 and up, they recommend getting an additional dose. And then this most recent iteration has removed that recommendation, and it's strictly for those who are immunocompromised. So we've updated that by striking that from the language, and that's reflected in the updated link at the bottom. And the next adjustment is on page 16, where we amended the beyond use date for Moderna. Since it came out, I believe around 2021, it's always been 30 days upon refrigeration, and they changed it to 60 days. And the vaccine wasn't even being manufactured at the time of the August PFAC meeting, so there was no way for us to know this. And again, we were counseled on the fact that this was not considered a substantive change, so we were allowed to make that for your review. And we'll scroll down to the end. Several of the package inserts is, again, the vaccine was not manufactured at the time of the PFAC meeting. The package inserts were not available. And so we made it known at the August board meeting that we were going to update those as they became available. And then there you have those updated links to the 2024-2025 iteration of the vaccine. And President Chen.
Very much, sir. So is there any board discussion regarding these non-substantial changes to vaccine protocols? Hearing none. Yes,
Board Member Patel, so you're saying the protocol we have in the pharmacy, you have to discard and print new protocol, keep it in the pharmacy, or can we just strike and write down 60 days? No, that's one is new, you're right, like it's just come out, like, hey, once you put from freezer to refrigerator, they have only 60 days. Asking, just to save some trees.
Staff Member Runyon, I'm not making any claim as to what needs to happen there. These will be updated on the website and available through the board website.
Member Kirkbride, I don't believe there is a requirement to print the protocols. That's kind of the old way of doing things where you had to print them and sign them. So I don't think you have to print them. You can access them electronically for your reference.
Go ahead, Board Member Kroger, and then I'll make a comment.
It's a different topic.
So I appreciate the comment, but you just never know when the inspector come, if we can't access protocol, whatever reason. So anyway, thank you.
yes, Board Member
Kroger. This protocol with this change will be effective
That's what I was gonna say.
in December. No,
Staff Member Melvin. So we have the authority. I can update what's on our website today for the pharmacists that they're using the references that he mentioned and let me scroll back down to it. The 30-60 day was the question, Board Member Patel. So in real time, I can amend that right now because it's not considered substantial. At the same time, we're sending this through to the November rulemaking hearing so the public has an opportunity to provide public comment on this. Then in December, what you're adopting is what you saw in the OAR. The version is the only thing that's going to change on top of what we've amended right now. Does that help?
my concern is not with the 30-60 days. It's the ages 12 and older. What's it, page 10? Yeah, page 10, special situations for people ages 65 and older. That changed because now we have a temporary protocol that would allow that. ACIP has changed recommendations. Is that this is similar to the 60-day change? Is this going to, are we going to notice the licensees that this is no longer essentially allowed to give that additional dose, right? Like, that's the concern. We've got two protocols that I feel like is actually kind of more substantially different than a 60-day expiration date.
So I guess, I think when we were talking about what I was understanding was that this was just what was going to be noticed. And not what was, we're gonna change the temporary rule that's out.
Other than the references at the bottom, which we can. So, so yes, you need to help us
Yeah.
deliberate this
Yeah.
because, so typically this would just go to rulemaking hearing and you wouldn't see that be removed until December when you vote on it permanently. So the 30 to 60 day, we can amend now in real time, and this one needs to go to rulemaking and we cannot amend in real time. It's a 2-for-1 here.
Okay, so I think probably I don't know that I'm following you, but what I think probably needs to happen is if everyone is okay with these changes, then we do withdraw the previous temporary rule, issue this as a new temporary rule. And then move forward and then send this to rulemaking for permanent. You wanna take a minute and discuss it?
Yes.
Okay.
So yeah, because there's issues with filing a temp on top of a temp.
Yeah, that's what, yeah.
That's the issue with this.
So this is the conundrum when it changes and changes and changes so quickly.
Yeah.
And how do you? I mean, how do we keep our rules up to date when AACP updates it more quickly than we can update it?
I think we see these are special circumstances with these vaccines that have such quickly changing recommendations. My concern is that a pharmacist gives this additional dose to somebody, based off of what's highlighted. Now, like, what is would disciplinary action be taken? Like, what, we've got this kind of like gray zone here. What would we do as a board there? Because, I mean, like you said, we've got temporary rules, non-temporary rules. How do we notify our licensees that, hey, while the temporary rule says this, permanent rules come in December, but in the meantime, here's what could happen.
So I think personally that you can send out education bullet points, but I don't think that if got a case that said you followed an old guideline and you gave me an extra dose of COVID, knowing that, where we are in temporary, permanent rules and the changes that AICP makes routinely, that we're going to take that case as, or that we're not going to sanction that licensee. I just don't see that. People can make complaints all day long about how we do vaccines, and we can do sometimes, but it doesn't necessarily mean we need to take action on it based on mitigating circumstances. And I think this is gonna be one of those mitigating circumstances unless we figure out how to do the temporary.
Staff member Runyon, if I may, what I would like to point out is an argument that I brought up when the PFAC entertained this as a possibility in the August meeting. The vaccines didn't come out until mid-August, and following this, an additional dose would not be available until 4 months after the updated 2024-2025 dose. So at best, they would have gotten it, prospective patient would have gotten it mid to late August, which would 4 months from that point would put it beyond the December meeting, which is when they're suggesting that the permanent rule be adopted. So while speaking in generalities, I definitely understand those concerns. And if this were a 2-month time frame, that would definitely be relevant in this case. But specifically speaking, since it's a 4-month interval, and this was just lifted from the 2023-2024 protocol, and that's something we had considered. And even if they did away with this provision, and it took us a couple of meetings to change it, it would still be outside or within that 4-month window.
Excellent information.
Right, that's of course, like, actually.
Right. Do
that. So we're okay. So just moving forward with the-
Good questions, and thank you
Yeah.
for
So we don't.
The fine print.
Member Kirkbride, I just wanted to offer an additional comment. We are a unique state, right, with these protocols, and even when they were OHA, have been many times in history where it didn't match up with BSIP. So, I don't, while I hear that concern, I don't think that's a big issue here. The protocol, the version that was in effect on the day the care was given is what the pharmacists would be held to. It's unfortunate that there are gonna be times that that doesn't match up until we have this streamlining happen. But that's my thought on that.
Okay, all of the comments. Any other further discussion?
Okay, so staff member Melvin said the next protocol we need to open is mailing B, little b. So give us just a moment.
Staff member Runyon, similar to the COVID protocol, the only changes we made to the inactivated influenza protocols were to the links at the bottom, with the updated package inserts and I believe a couple of updated primary resources. So all of those that you see there and for the different products that are available are the 2024-25 versions.
And then if this is okay with the board, we'd just like to continue with mailing B, C, and BD and then go back to board discussion. Is that all right?
Would be fine, thank you.
Thank you.
And staff member Runyon, that's actually the case for the next two as well. So for the live influenza or the flu mist, and the only updates were to the package inserts and references at the bottom. And it was the same case for what will be the RSV vaccine when Rachel pulls that up.
Okay, while you're pulling it up, I think we're comfortable with or opening up for board discussion. We already discussed the coronavirus. They've added package insert information on the inactive and live flu vaccines and the RSV vaccine. Is there any further discussion on those? Member Kroger.
For the RSV vaccine, and I don't know, I did not review this close enough in the previous meeting, but the FDA approved range is not, I believe, accurate. I don't know if that's been reviewed for XP.
Staff member Runyon, you are correct on that. I would also draw your attention to, I believe it's page 9 of the COVID protocols. It's the same instance there, and whether right or wrong, what I believe the PFAC's intent was with that column of FDA approved age range is actually supposed to reflect what the Oregon pharmacists are available or are authorized to administer and that age range. Because if you look at the COVID protocol, it says FDA approved range age 3 and up, but we all know that it's 6 months and up from the FDA. So the same thing that you're pointing out here is also in the COVID protocol. So I believe that was their intent in creating the heading in that column, and whether right or wrong, but it's also present in the COVID protocol.
So pharmacists in Oregon are not allowed to vaccinate 50 years and older for RSV. Is that my understanding?
My understanding was that they needed a prescriber to, that's what I think I remember reading, that 50-year-old would need a prescription from their provider for the pharmacist to give the RSV vaccine. Why that, and I don't know the
For 50
reason.
to 60.
Yes, but that's what I remember reading, so. I have a family member, immunosuppressed, she got the RSV vaccine, but the pharmacist said they couldn't give it to her. She would need to go to her PCP, get a prescription to get it at her age.
Okay.
That's what I recall reading.
Staff member Runyon, though I do agree that that perhaps should be reworded, and that would be an issue, I feel, for the PFAC. Entertain.
And with the chronic underlying medical condition piece that changes, especially for those with diabetes, those changes as well. Does that need to go back to PFAC as well?
Actually, I would refer to legal counsel on that, and in the manner similar to what we saw with the chart on the COVID vaccine protocol, and whether or not that would be considered a substantive change, which would be outside of our scope, because essentially they're expanding the scope of conditions that would constitute someone being moderately to severely immunocompromised. So they've added some additional definitions and additional qualifications there.
This is board member Chen. I thought I read that in this protocol that those additional conditions were written in here. Specifically remember reading about the diabetes one.
I didn't see it in there, but if it's in another section. Treatment with insulin, so it was just.
We don't give RSV at my office, and so I was really interested more in that one because I'm just not versed on it. So I read that one through, and I do remember reading information about the chronic conditions and how they're layered for severe and moderate and blah, 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 but diabetes and complications with diabetes were definitely mentioned and listed.
So staff member Runyon, you're correct, they are in there, but there were some additional qualifications that were added compared to this chart that was available to us in August. For diabetes, for example, if they're on a sodium glucose transport 2 inhibitor, like your Invokana, then that qualifies technically. If they're on insulin, that qualifies, and that language is represented in the most current iteration, but is not here. Severe obesity or body mass index greater than 40 is included in the new language, and it's not here. And there are a couple of other things. So while the majority of conditions are represented here, there are a few additional qualifications that are not.
That those are there, I think, first, diabetes being treated with insulin, that expands that quite significantly, possibly. And I think access to vaccines and making sure that those who are at risk are able to get that through pharmacies is important, but I don't know what the process would be to making that correction or addition.
Remember Patel?
Remember, but this is what does not make any sense, but sometimes it does not have to make any sense. So patient needs RSV, they